I just kind of want to hear a group consensus about, so you have both the BCMA target and you have the GPRC5D target, you have bispecific antibodies, and then you have CAR T therapy. So some of this might be just availability issues and what you can get when, but what's the logic between maybe, like you mentioned, maybe doing CAR T first and then doing a bispecific later? Which target do you go after first? Do you try BCMA first and then you move to GPRC5D, or what's the strategy and the thinking behind that? I'll let you start and then we'll open it up to everybody.
Yeah, no, these are really, really pertinent questions. If you're looking for consensus, I don't think you get that from a bunch of myeloma physicians. I'll tell you that right off the bat. But,
Yes.
And a
Or
lot of that is
different
because we
opinions.
don't really know yet, right, what the right sequence is. There's no reason to think BCMA should always go before GPRC5D. There's no biological reason for that. We just, the sequence of kind of how these therapies were approved is kind of dictating, what we have available. So when you have, 4 different BCMA targeted agents, it used to be 5, and 1 GPRC5D, you're starting to see kind of, the availability there, and the GPRC5D is just recent, right? We still haven't even had our first patient like commercially treated yet because it was just approved, although we're close. So I think it just comes down to what we have available, but I do think the opposite sequence could be fine in terms of the target. With that being said, I think the bigger question is, bispecifics or CAR T, right? I think that's really what I highlighted a bit before in the talk. Some of it is so circumstance dependent that it's out of our control. For me personally, if I could get patients BCMA CAR T cells, particularly with CARVYKTI, and if we think we can manage their disease and they can tolerate the toxicities, I find that to be, what seems to have the highest responses and the longest responses than what we've seen. And then when you're off therapy for a few years, hopefully with that, you're not going to have as much exhausted T cells. You're still going to have potentially the target, but now you have a new target that you can use there. So to me, that sequence makes the most sense, at least as of today, where you get a BCMA CAR T cells, be off therapy, and then maybe get a GPRC5D bispecific antibody. But a lot of this is still to be determined.
Mm-hmm. Okay, any other comments?
No, I mean, I think Dr. Nadeem covered it pretty well. We do have to think about the T cell milieu and, the fact that with both agents, bispecifics and the CAR Ts, we are exhausting those T cells. And so, figuring that out a little bit earlier, and I think he alluded to in his talk about considering a collection of those T cells earlier, because that's going to make a huge difference in terms of how patients respond and what the outcome is going to be on the back end. And I think also figuring out the dosing schedule for a lot of these bispecifics. Many of the medications that we use, we kind of figure out how to use them in the real world setting. So, the wonderful story of Velcade, as we all know, is a perfect example of that. So thinking of using the bispecifics post-CAR, we may not necessarily need to use them as they're currently approved. Maybe we'll be spacing them out monthly, who knows. So I think a lot of the story is yet unfolding.
And go ahead.
I would just add that I think one of the biggest determinants too for us is really patient selection and what patients are able to do. And when we have, a question of a patient who may be more
Too much.
I must be close to something. Maybe we're too close. Maybe. We'll try that. Much as I like sitting next to you. Let's see if we can make it. I think that the question, one of the largest determinants, in the absence of data in terms of, as Omar said, which of these targets might be most beneficial, so much of what drives our decision making are the characteristics of patients. And so would they benefit, are they able to get a CAR T cell? Are they fit enough? Does their disease have the type of kinetics that would enable us that period of time where we can collect them versus using something off the shelf that's readily available? And also, what therapies have they seen before? So there's both what we know about the drugs themselves, but it's also how it fits into the patient context that dictates our decisions.
Okay, well, you both mentioned this, earlier T cell collection. So like stem cell collection, a lot of us have been through stem cell transplant, and you have that collection process, and you can put those stem cells in the freezer and pull them out even for things like reconstitution during like bispecifics or CAR T therapy.
Yep.
Is that something that you think will happen in the future, that a newly diagnosed patient might go in and get their T cells collected before they go through any therapy? For CAR T?
This is something that we're certainly discussing and trying to do, absolutely. It makes sense. You can't, as of right now, you can't collect them at the same time, but people are actively investigating this and seeing if we can do this.
Yeah, I think that's currently being looked at in some of the smaller clinical trials. How best to collect the T cells, how long can we store them for, and also ways that we can use the stem cells that have been harvested for other purposes, because a lot of times we collect more than we actually use, and so all of that is actually a part of some of the things that are being looked at right now.
And does somebody want to talk about how you can use some of your collected stem cells after CAR T therapy and mention what that is? Because I don't know if everybody knows what that is.
Yeah, I can take that. So kind of going back to the T cell question a bit, I mean, I think all of us would love to do that, because we think it just makes sense. I think the issue is really logistics, because right now, it's not like we can store it, and, kind of insurance probably is not going to cover that. And then is the company 5 years from now going to use those T cells to make the product, right? We don't know. So there's a lot of this sort of uncertainty area. So I think, like for stem cell collections, we have control, right, as academic physicians and centers to say that's the right thing to do. We can store them here, and we have the ability to do that. I just don't know if we have the ability to do that yet with T cells, but we're certainly advocating for that, because you're right, there's really no reason. And then you can certainly use them later from a, they still work. It's not like, we know that part. It's just that I think the other piece we still have to sort out. In terms of stem cell collection products, I mean, a lot of patients are now having their stem cells collected. Either they'll go right to upfront transplant or they'll defer transplant. But when they defer transplant, I always have this conversation with patients when you're sitting there then 5 years later saying, okay, do you want to do a transplant? The answer is still no, right? Many times, because you didn't want to do it the first time. Like, now you have all these amazing therapies, like who would choose transplant? So it becomes very difficult. In many circumstances, you have this stem cell just available. There are other uses for them, as you pointed out. I kind of mentioned a little bit briefly in my talk that you do get low blood counts in some patients post CAR T cells. Some of those can be prolonged, like we're talking months and 6+ months, where patients are transfusion dependent. We don't exactly understand why. We don't know if that's because of just kind of the inflammatory immune response that the patient has had, and that's just leading to this constant suppression of their bone marrow. But I've personally given those stem cells back to patients in that circumstance and have recovered their counts. So it's not like we do the stem cell collection for that purpose, but know that there are other uses for them in the future. So that's one example of where we've used them recently.
So you might have some stored in the freezer for later, just so you know.
Yeah. So definitely do your collections, because I don't see that's what I tell patients. I don't see any downside of doing a stem cell collection, when you're first diagnosed.
Okay, I have a question then. If we're talking about T cell exhaustion, and sometimes that's just being on myeloma therapy for a long period of time, or the myeloma itself, or for whatever reason, the T cell, or from immunotherapy, T cell exhaustion. I saw some research being done at MSK in lymphoma that was using an approach to handle, like, this oxidative stress they were using like antioxidants to overcome the oxidative stress to get the T cells back in function so they could actually function after some of these therapies. And I've just wondered, and especially Dr. O'Donnell, like when you're thinking about diet and things like that, because you're going to be speaking about that, is there anything, patients always wonder, what can I do? Is there anything that we can do as patients to increase our T cell function through either exercise or diet or things like that?
So that's a great question, and we don't have a good answer to that as of yet. One thing I will be talking about today, though, is our ongoing study of the microbiome that we're doing at Dana-Farber. So the gut microbiome are the bacteria that line your GI tract. And there are data also out of Sloan Kettering that suggests that the microbiome can affect response to immunotherapies. And so I'll talk about that in just a few moments. But these are some of the things that are under exploration, but that we do not have good answers for at this point.
Okay, we are going to support your work then, because we need the answers to what we can do about this. Okay, can we talk a little bit about quad therapy or the use of monoclonal antibodies like isatuximab, daratumumab in the earlier line setting. We saw the results from a trial called the Griffin study that was using DARA RVD versus RVD by itself. So for newly diagnosed patients who are going in, and usually it was this triplet combination or isatuximab, Velcade-dex, or using Kyprolis instead of Velcade. But what's your opinion in terms of newly diagnosed patients getting a quad therapy versus a triplet therapy or using quad therapies later?
I'll jump in with that one. I think based on the Griffin study and the Maya study, many of us are using either a quad or triplet, which includes daratumumab or an anti-CD38 monoclonal antibody. Essentially, it's daratumumab at this point. Isatuximab is approved in the second line and beyond. But we've seen that doing the quad, and there's information coming out of that German trial, which is the ISA-RVD, it's really potent, and the MRD negativity rates are pretty high, and they deepen over time based on the Griffin study. Now, the Griffin study, it was a phase 2, so it's not powered to give us overall survival, but the progression-free survival, the outcomes that we saw with that trial is so compelling that a lot of us, I would say, are utilizing that quad up front for many of our patients. And also, it doesn't seem to be affecting, if the patient is a candidate for a stem cell collection, it doesn't seem to affect the collection process. So we're still getting good yield for collecting stem cells in those patients. So I basically, when I see a patient come in and I consider them transplant eligible, I will offer them that quad. Sometimes it changes in terms of the maintenance portion of it based on the patient and the cytogenetic risk profile. But for most of my patients who are older, over the age of 70 or 75, I would say actually, I usually will kind of think of the Maya regimen with the DARA RD because, again, very well tolerated, and the outcomes are favorable for the patients who receive that sort of triplet. We don't have a head-to-head of DRD versus RVD. I don't think we'll ever get that, but we'll look across trials, and a lot of times it's just nice to have that option. But what happens is on the back end, when you're looking at second line and beyond, then you're starting to see that if they fail a DARA-based regimen or an anti-CD38 monoclonal antibody, the disease tends to be a lot more aggressive, more difficult to manage. And so we would definitely like to use some of these BCMA-targeted therapies a lot sooner.
Okay, any other comments?
No, I think we are noticing and discovering that these are therapies that many patients with myeloma can tolerate if you just dose them properly. So even though it's 4 drugs, you can give much lower dose Revlimid, you can give Velcade once a week, maybe take away a week and just give it for 3 weeks instead of 4, bring the steroids down, give the DARA. Like, we haven't seen significant increase in toxicity, so essentially most people are now just getting a quadruplet, even if they're older, even if we think they can't handle a stem cell transplant. It hasn't really, I think it's really made it more widespread use recently because of just the additional deep responses that we see with the 4 drugs versus the 3 drugs. But it's very individualized, but that's where the field has shifted.
Okay, jumping off that topic to just vaccinations. I've had a lot of patients ask me about the RSV vaccine. Can you all weigh in on whether patients should get that, not get that? And I mean, as we're heading into maybe cold and flu season in the fall and winter, what do you suggest for patients?
I mean, I usually tell patients get it all because, I don't see a downside, right? It's going to give you some protection. It may not give you 100% of the protection that other patients are getting, other people are getting that are not on these combinations, but why not take what it can give you as we're entering the flu season, right? So it's all these different viruses, different strains, and I'm usually pretty liberal about just recommending it.
When we did our COVID-19 study, we looked at the immune system in patients who had no plasma cell disorder, patients with MGUS, smoldering, and myeloma, and we see even patients that don't have treatment but have very early MGUS have a lower immune response than patients, than the healthy individual. And so I think that speaks to just the more protection that patients with precursor conditions, even if they're not immunocompromised due to treatment, the more protection that they can have, the better, particularly as we're going into these cold and flu seasons, which have been bad the last couple of years.
Just to follow up on that question, what would be the timing of getting those vaccines if you are on, a monthly treatment or a weekly or, every 2-week treatment?
I tend to tell my patients not to do everything at once. We know that with the anti-CD38 therapies and the anti-BCMA therapies, you really knock down the B-cell milieu, you've knocked down the immune system quite a bit. So for somebody who is on those therapies, on a maintenance setting, just try to get it in between when you're dosing your medications. So if you're, getting your treatments every month, you have like another, 3 weeks to figure it out. Maybe the second week of that month after you had that treatment, you could go in and get your vaccinations. And I also agree that, any protection is better than none because I've seen a few cases post-CAR, post-transplant, and the RSV was not, it was protracted, it's uncomfortable, and we really didn't have anything to offer the patient other than, management of symptoms. And so if there is something that you can do, definitely do it. It's not a guarantee, but it's worth having a little bit of something on board.
Okay, and write down your questions because we'll have an extended Q&A period as well. So, okay, another question about fish testing. And Catherine, I don't know if you want to address this, but Dr. Gobriel was mentioning instead of fish testing, or maybe all of you can, instead of fish testing, what's better than fish testing in terms of determining risk? She was mentioning whole genome sequencing. So can somebody talk about better ways that the whole precursor condition work that you're doing is trying to assess risk and determine who's going to progress, who won't progress, who's going to be aggressive, who's not going to be aggressive. What other tools are there that we can use to do a better job of identifying the right treatment for the right patient at the right time?
Yeah, so when we're thinking about sequencing patients, right now we have to use the tools that are clinically available, what can be returned to patients. So these novel approaches of sequencing an individual's bone marrow samples are really exciting, and I think that there's a lot of promise in terms of using that information, returning it to patients in real time. That's not an option for patients on an everyday basis. These are laboratory developed, they're not FDA approved, but it's a really exciting area that I think is on the horizon. And it's something that, all of the samples that are contributed as part of PROMISE and PCROWD, every patient that we have in our clinical trials at Dana-Farber go on these banking studies so that we can understand and profile and sequence patients to understand, are there features in the bone marrow that are predicting an individual's response? How can we better tailor those regimens? And so I think, obviating fish testing with something more refined in the future is definitely on the horizon. It's not there right now.
Yeah, so that's a perfect response just in terms of the available technology. And I think the important thing to understand here is when we do risk stratification, it's a pretty crude tool right now because we really rely upon the quantity of disease that a patient has. And so I'm sure we're all familiar with some of the different, metrics that we use, whether it's the percent of plasma cells in the bone marrow, the amount of monoclonal protein, or the skew of the light chain ratio. But we know that there are a lot of other factors. If you follow patients over time, they're not intangibles. We just aren't able to actually capture what the factors are that put people who might look the same on paper at different risks of progression. And so are there other mutations? And yes, we can find new types of mutations through whole genome sequencing, but those are not available. But we think beyond that, there are other features too. Is there something inherent about a person's immune system? One of the things that we're looking at is the T-cell repertoire, and are there different signatures that we may be able to identify that help us complement the information we have to actually bring in an individualized appreciation of someone's immune system and whether it's permissive to the disease progressing, but we don't have that information yet. We know there's more to the story, but we can't provide it, but we're studying it.
Yeah, I would say that having the capacity to do the whole genome sequencing is nice, but because we do not have all the information as to, how best to utilize that, it's just not ready for prime time. But I think, the things that are being done in terms of sorting that out is how we move towards that personalized medicine, where you can potentially find a patient who by FISH would be categorized for all intents and purposes a standard risk patient, but we all have those patients who, despite being categorized standard risk at the time of diagnosis, behave more aggressively in their disease course and throughout the journey of treatment. And so, having that whole genome sequencing might be helpful right now in the laboratory setting and in the preclinical translational setting. But I think, we still have a lot of work to do to figure out exactly which areas are affecting which patients so that we can figure out how that matches to the therapeutic path that patient takes.
Okay, and I would assume, maybe you can raise your hand if you know what kind of what genetic type of myeloma you have by your FISH. Do you know? Okay, a lot of you do. If you don't, I think, and you're all, you're at one of the world's best facilities. So I'm sure you look at FISH testing too to see, okay, what does the tumor burden look like you're saying, the amount of myeloma, what do the genetics look like, and then how do I treat this patient from the get-go? Because a lot of our times, well, maybe not in the age of CAR T and bispecifics, but usually people would say your first therapy is your best therapy, and things like that. So can someone talk to, or all of you, talk to the importance of understanding the kind of myeloma that you have as a patient?
So I'd be happy to take that. So there are two elements to this. I'm not sure this is working. One is when we talk about the kind of myeloma, there's the actual type of protein that your plasma cell is producing. So that's whether you're IgG, IgA, kappa light chain, lambda light chain. So that's just the description of the protein that's being made by your cancer cell. The cytogenetic component of this is something different. That's a look at the biology of the cells themselves. And so there are certain mutations that we can see that can be grouped into two broad categories of standard risk or high risk. And so maybe when you've had a bone marrow biopsy, you've gone over the results and they talk about the number or percentage of plasma cells that are present. And then the qualitative piece is what the biology of those cells are, which we get from that cytogenetic report. In addition, that report can identify other mutations that might be amenable to targeted therapies, such as the translocation 1114. While that is not something that portends risk, it is potentially amenable to being targeted by a specific therapy. And so there are nuances to what we get in that report, but broadly speaking, what we can interpret from some of the mutations is whether you are standard versus a higher risk. And those terms maybe have been used with you rather than going into the specific mutations. But sometimes we talk through those specific mutations as well.
Yeah, I'll just add that I think Monique alluded to this before. When I'm meeting a patient for the first time and they have X or Y results on their FISH, we acknowledge it, right? Just like we acknowledge the stage, we acknowledge what we're dealing with or potentially dealing with. But I always caution patients one way or the other, whether they have nothing on FISH or they may have something that may look like it could be high risk. We have to see how it plays out, right? We're still going to treat everybody, as you said, with our best therapies. We're not going to give the disease the benefit of the doubt, right? We're not going to suddenly say, oh, no, don't worry about it. I don't see anything there. Here you go, just take the Revlimid, right? Like we're giving everybody the same therapies. So where it comes into play is how their response is, and then time, right? Like time is what really tells us, So if people are 1, 2 years in, majority of patients with high risk or ultra high risk myeloma relapse within 2 years. So, once you kind of cross some of these thresholds, that's when we start to say, okay, you know what, we can maybe back off a bit and kind of do it in a more sort of stepwise fashion. So, we're just scratching the surface of what we understand, right? Because as Monique pointed out, you have patients with standard risk disease that, tend to relapse so early and surprise all of us, but that's only because we're testing for a handful of things. So, I think we acknowledge it, but not necessarily overreact to it one way or the other.
Yeah, and that's a good point, that sometimes you can have a genetic feature that is considered high risk, but you don't behave high risk. And sometimes you can have no genetic features and still behave high risk, right?
Yeah, so I would say, and I do say, just as you do, Omar, I would look at it like a bell curve, where we have this information and, you know, there's a solid majority that behave kind of as we think they will, but there are 10% who do unexpectedly worse than we would say based on cytogenetic risk, and then those who might have higher risk features that do even better than we would expect. So there are, you know, different parties or different groups on either end of the spectrum.
I'd also point out that, again, part of the story with the journey is that those mutations can change over time. And that plays a role in terms of, you know, what happens down the line. So, you know, I know having a bone marrow biopsy is not a fun process, but, you know, knowing whether there's a mutational change at the time of relapse can sometimes make a difference, because maybe we'll find that translocation 1114, or maybe we'll find something that would be more amenable to a certain type of therapy in the future at that time when the relapse occurs, because you know, the disease is changing based on the findings of these mutations. So, you know, the story's still
Yeah,
on.
that's a really important point. And I don't know if you've all seen before, there's one slide that everybody shows all the time that shows like a diagnosis the patient had, you know, 3 or 4 different types of mutations, and one clone grows up, and then, you know, and then they get rid of, and some never show up after that, after treatment, but then a new one grows. And so myeloma is wily and tricky, and I love what you're saying about making sure you are doing the bone marrow biopsies to see what your response is after and to see what genetically is happening. Can we talk about MRD testing a little bit too? As these therapies get better and better and better, and then we look at like trying to say, oh, overall survival, we're going to see how long patients live, or progression-free survival, how long do they stay in remission? I know people are thinking about MRD, or minimal residual disease negativity, as being maybe a new clinical trial endpoint. Can you talk about how you use MRD testing in your clinic, what you suggest for patients, and do you think it's going to be a new endpoint?
It's a complicated question. It's a complicated question because we all would love to have our patients reach MRD negativity. I guess my mic decided to. But oh, it came back. It's okay. So you know, MRD negativity, just like everything else, we need that to be sustained. So ideally, when you check for MRD negativity, it's usually around the time of you know, after induction, after we see that there's no measurable protein in the blood or the serum or the urine, and you know, all our markers are somewhat in the normal range, and we're like, yay, you know, you're probably in a CR. Let's see what the bone marrow shows. You do the bone marrow biopsy, you're not finding those abnormal plasma cells anymore. You do a deeper dive in there, and you get some results showing that in, you know, well, now we do clonoSEQ, but you know, in 100,000 cells, you don't find any of those that are consistent with your original myeloma cells. We can even go as deep as 1 in a million. But the point is that we've seen this over and over again, that even with MRD negativity, you can still get a relapse. And so now the question is, what's the sustainability of that? And so a lot of the trials that you see in their early phases right now have MRD plugged in at certain time points to try to gain that information to see how we can use this particular test to give us more information as how well we're treating our patients. I personally, right now, I don't use it in clinic as a tool for changing therapy or, you know, adjusting things. I don't use it as a tool like that in my clinic, but it's definitely something we're asking about in the clinical trial setting, and it does seem to correlate very, very strongly with the progression-free survival. Overall survival, thankfully, we've been pushing that out longer and longer, so you know, I don't think we'll be able to really patch it directly to overall survival, but definitely trying to figure out the best way to utilize it as an endpoint or a way to kind of tell how we're doing with our patient treatments.
Yeah, no, I think Monique hit all of them. Yeah, similarly, we don't yet know what to do with it in terms of adjusting things. And that's what now the trials are going to all do that. They're all going to incorporate some form of MRD adaptive design. And I think until for me, I personally see that, I hesitate because I don't want to make an MRD negative patient that was supposed to have a really amazing prognosis just because I changed something. Now they don't. Right? So I think that's, to me, that's kind of more of the risk of that, is that you're like de-escalating and you're saying, aha, we're done. Maybe we're not, right? So until we prove that, I just hesitate a bit. And then MRD positive patients, similarly, we've all had patients that have had even their M spikes around post-transplant on maintenance, and they're fine, right? So like, it's just a tool, and I think until we know better how to use it, we can always get prognostic information out of it. So if somebody wants to know, I have no problem ordering it on a bone marrow biopsy, but we just have to acknowledge its limitations, at least right now.
Okay, great. And then you talked about bispecifics and infection risk. I know there's some with CAR T, but it seems to kind of dissipate after a season. What else can patients do to reduce? You mentioned IVIG, but what can they do to prevent infections if they use bispecific antibodies?
If you have the answer to that, please let me know, because that's what we're trying to figure out and keeping us up at night. So.
Yeah, I think this is a really important topic, though, because this is a broad audience, so not everybody is potentially at a tertiary center. So what is IVIG? It's intravenous immunoglobulin. So these therapies are so effective. Remember, your plasma cells, your cancer cells, we're trying to get rid of those. Those are the very cells that make your immunoglobulins. So not surprisingly, when we're giving you these treatments, we're reducing them significantly. So when you follow your immunoglobulin levels, which is done every month when they send your SPEP, if that number falls below 400, or even if it's higher than that but you're having infections, you should be advocating for the use of intravenous immunoglobulin G, having that being given to you to support a higher level. That's the one thing we know that can help. And then sometimes patients belong on prophylactic antibiotics. We don't know the right answers, though, as Omar just said, and this is really what we're learning as we do these therapies long term. And over time, perhaps we'll back off these therapies and dose them less frequently. But I just want to make sure everybody understands what that terminology means and that that is available to patients.
And I had to say one more thing is, aside from that, when you're talking about these post-CAR T and post-bispecific therapies, sometimes patients can get severe cytopenias. So low white blood cell count, which is neutropenia, a low red cell count, which is anemia, and a low platelet count, which is thrombocytopenia. We do have growth factors for each of those different lines of cells. So sometimes you will find, you're coming in for, assessment, and you may get an injection of, Nupen or Grant, whatever you want, whatever product, but to boost your white count, or Epogen or Procrit to boost your red cells. Because we know that those things will help to support your immune system, but also prevent you from being in the hospital, prevent you from requiring too many transfusions. Also has its own downside. So all of these things we're utilizing to try to support our patients who may have severe effects post treatment.
Okay, and with CAR T therapy and some of these immunotherapies, when you're thinking about, you talked about sequencing and maybe we should use them earlier, and you're even thinking about them in the high-risk smoldering setting. When you have patients come in to determine, let's say they've gotten their first therapy and they're trying to determine line 2, do you suggest that they look at clinical trials earlier, or earlier rather than later? Because if it's a spot availability issue, you still might be able to have some therapy, but in a clinical trial setting, and it's spots that are available, and maybe sometimes it's randomized, so you have a 50-50 shot. But how do you because I feel like having myeloma is like a chess game with my life, And what can I do and be the smartest possible patient about my treatment and approaching it in the right way? So I have more options later, yes, but then I'm taking advantage of the best things as early as possible.
We're a little skewed. So I think most of us would say, think about a clinical trial from the get-go. As you mentioned, it's a very difficult disease. It's heterogeneous, and you know this. I mean, you've talked amongst each other, and one person's journey and process has been completely different from another person's, even if you do have the same kind of information about your myeloma. So I think early on you should be talking about it with your provider, and just keep in mind that the clinical trials that are available at that location you may not be eligible for, and that's not a downside. That's just the fact that you're interested, you want to participate, because the way I think of clinical trials when I talk to my patients is you want to be a participant in something that is going beyond the standard of care, right? We're challenging the standard of care with a clinical trial. So you are going to get treatment, but you are going to get something beyond what we're typically doing with the standard of care regimen, with the hopes that your outcome is going to be much more favorable, and down the road we potentially will have this new treatment as a part of the milieu of things that we can manage this disease with. That being said, there is always a risk with a clinical trial. So that's why we have the eligibility and the exclusion criteria to try to be safe about the choices of patients and who enrolls in the trial and things like that. So that's also a part of the process. And then if you're not a candidate for a clinical trial in the newly diagnosed setting, you may be a candidate at relapse. So always ask about the clinical trial, because it may be something that will be very helpful for you.
Yeah, the only thing I'll add is, I think this all comes down to your relationship with your provider and the team, right? You have to trust each other, and you have to be comfortable voicing, what you want to do. And I think that's really important, because there's so many different ways to go at any given juncture. You have to trust that your provider is not going to offer you something if they didn't think it was in your best interest, right? Because we have so many trials, and I might say to a patient, listen, this is a trial that we have, but I don't want you randomized to the control arm on this study because you've had X, Y, or Z. So trust us when we're telling you there's a clinical trial that may be right for you, because not all of them will be right for you. So clinical trial is just kind of a catch-all phrase, but it's very individualized. I had discussions earlier about using CAR-T in the frontline setting because we have a trial open for that. Yes, there's unknowns with that, but if we feel like maybe it's going to be better than the standard path, it's a discussion we just need to have to look at the pros and cons, right? So none of us can guarantee anything one way or the other, but they're all very different, and they're never going to be putting you on an inferior treatment or placebo, which a lot of people worry about. I think it really just depends on your own circumstance.
And can you all speak to, I know there are some people from New Hampshire and people traveling in to come to the Dana-Farber area to see you as a specialist, and then they go home and maybe get their infusion at home. Can you talk about how you work with, as a specialist and then with a local provider, and how that relationship works? Because sometimes I think patients don't know that that's possible. And I think they need to know that they can come and get a consult from you if they're making a treatment decision. It's a really important time to come to talk to you all, and then go home and get an infusion somewhere else.
Yeah, so this is a really important question. First of all, doctors want to partner with one another. So it is okay to have a second opinion or come to a tertiary center and see a specialist for your cancer, and we are happy to work with your community provider as well. Myeloma therapy, as most people in this room know, is an arduous process where you have to come weekly, very frequently. So you need to set something up that's compatible with your life. And for people who don't live in close proximity to Boston, it is very reasonable, considering that we have such good standard of care therapies, to do those locally. What I would advise is having an opinion at a tertiary center for two reasons. One, I think it's good. It's much, in a sense, we're fortunate that we only do one disease. And sometimes in local practices, they're doing many different diseases. So having that area of expertise to help guide therapy, to make recommendations about dose reductions or supportive therapies can be very beneficial in a partnership with your local provider. But going back to the last question too, something like newly diagnosed myeloma, they're a very good standard of care. But as you go beyond second and third line therapies, some of these important treatments are only available at tertiary centers and may not be available in community practices, particularly the immunotherapies. So having that relationship enables you to have two things. One, the ability to get specific therapies that are not necessarily available locally, and two, to participate in clinical trials. And so once you establish that relationship, you can check in. You don't necessarily need to come to Boston, but you can check in and say, this is where I am, or have your provider check in. And that creates the opportunity for you to have a broader range of therapies available to you.
Okay, I would like to thank this amazing, esteemed panel. Let's give them a hand.